All right, looks like we're ready. So good morning or good afternoon, depending on where you are. Welcome to the August version of the Australasian Pleural Seminars. Today, we are delighted to have Dr. Saghaie, who is an interventional pulmonary consultant in Sydney at the Macquarie and Concord Hospital, to talk to us about medical thoracoscopy, something that obviously you're all very interested or have been involved in. Just a reminder that you need to type in the questions on chat so that we can actually see it. And feel free to put in all the questions that you want to ask. This is the best time to ask the expert. And our next version will be in the first Wednesday of September, and that will be Dr. Fitzgerald from Ireland to talk about why people are breathless with a pleural effusion and other interesting topic. So I'm just going to hand over the Zoom to Dr. Saghaie, and welcome and thank you very much for talking to us today.
Excellent. Thank you. Thank you, Gary. Thanks for the invitation and thanks for the opportunity to, having included me in these excellent seminars. I've been very much looking forward to this myself as well, and specifically, I'm trying to angle this 15-minute talk to sort of as an introduction to medical pleuroscopy, hoping to have some Q&As and discussions at the end. But as when you say the expert, I kind of thought to myself, why am I doing this? Why am I the one who's giving this talk? And I really owe this to obviously yourself and people like Matthew Peters, who really supported me to pick up the medical pleuroscopy service at Concord Hospital more than 10 years ago. I came over to Perth and joined a course, the CTEC course that you were running with Martin. And that was really the turning point for me, because I met David there, and he became my mentor, kind of a remote mentor, and I've learned a lot of the stuff that I do these days from these guys. So acknowledgements to them. Just a little bit about what I do in relation to this talk. I do medical pleuroscopies in a procedure room at Concord Hospital using a semi-rigid pleuroscope made by Olympus. It's the LTF 160 model. As you can see, it is a sterile procedure, and this is how we set up and do it. Obviously, I use forceps for sampling the pleural space, but I also use cryo probes as well for that purpose. I'm trying to keep it, as you say, punchy and to the point. I'm aiming for about 15 minutes of my slides. So I'm going to go through a little bit of history, because I think that's important and kind of clarifies a few things about how we see medical pleuroscopy today, and then sort of try to clarify what it is and how it compares to the surgical options. So this is, I'm sure a lot of us and a lot of the audience have heard this before, that this is a very old procedure that was invented or introduced by a Swedish internist more than 100 years ago in 1910. Jacobius described this procedure alongside laparoscopy, and he named it thoracoscopy. And the initial indication was for treatment of TB by introducing pneumothorax. And then a few more papers came out in the following decade on expansion of its indications, specifically talking about sampling. Things started fading away after chemotherapy for TB. Drugs for TB were invented, and introducing or inducing a pneumothorax was not done anymore for treatment of TB. The term pleuroscopy starts popping up in North American literature when some people started using bronchoscopes inside the pleural space. And as you can imagine, they struggled with it. A couple of years later, the first semi-rigid pleuroscope was made in Japan. However, it really feels like there were two sort of pathways that were moving along parallel to one another. One was in Europe and the other one was outside Europe. And Europe kind of stuck to the rigid thoracoscopy that was invented there and kept that going. And in the 80s with Bhutan and a few others, had a bit of a renaissance. They had 2 meetings and tried to train more people to continue this procedure. And things started changing after video-assisted thoracoscopic surgery was introduced in the 90s and pretty much took over some of that stuff, specifically outside Europe. However, I think in 2003, we had I think Olympus made the semi-rigid pleuroscope, and then later in 2007, the model that was autoclavable was made as well. And this is pretty much what is used these days. Pretty much what I have now these days as well. But the question is, what is medical pleuroscopy? Is it a procedure that the referrer would ask for when they can't find a surgeon? Is it the second choice when the patient is too sick to tolerate VATS and it's seen as the, we can't have VATS, might as well settle for the second best? Or is it a poorly done thoracoscopy, pretty much surgery that is done by a physician in a bad way? Or really, is it an alternative to VATS, which in some cases, in selected cases, could be superior to it? To be honest with you, I think it's all the above. And it really depends on how you define it and how you establish your own service and your referral base. By definition, though, medical pleuroscopy, also known as medical thoracoscopy or just pleuroscopy, is a minimally invasive procedure that allows direct visualization and access to the pleural space. So really need to sort of clarify this no man's land, this kind of turf war between surgical thoracoscopy and medical pleuroscopy, not just because we want to kind of see which referral goes to whom, but also to highlight and understand what the advantages of medical pleuroscopy are. I've made that this slide, this table to highlight a few things, but I would like to acknowledge the fact that things are very variable. Not much on this surgical side of things, because surgeons do things in a much more controlled and neater way than we do as interventional pulmonologists or pleural specialists. You don't see a lot of variability in how VATS is done in different hospitals by different surgeons or in different countries even. But you do see a lot of that with medical pleuroscopy. And I'll try to sort of touch on that as well, because I think these variations are where we either succeed or fail in highlighting the advantages of a niche procedure like medical pleuroscopy. One is in indications. Obviously, VATS can access and operate and does access and operate on lung and pleura, both therapeutically and diagnostically. However, the advantage of medical pleuroscopy is mainly in the pleural space, and specifically also in the parietal pleura and not visceral pleura. Again, I acknowledge the fact that in Europe, for example, they do even lung biopsies doing medical pleuroscopy. The setting, surgeries are done in operating theaters. Medical pleuroscopies are usually done in procedure rooms or bronchoscopy rooms. Again, I'm aware of in some centers that the physician would do their medical pleuroscopy in theater, with an anesthetist and sometimes with an LMA and deep sedation. And that kind of pretty much defeats the purpose of its advantage. Again, medical pleuroscopy is done usually under local anesthesia and conscious sedation if required. Surgery is done under general anesthesia and often paralysis because patients are tubed with a double lumen ETT and single lung ventilation. With pleuroscopy, they hold their own airway and spontaneously breathe. Medical pleuroscopy is usually done with one port, surgical thoracoscopy at least 3, sometimes 4. Again, in some centers, they would do medical pleuroscopy with more than one. Again, it kind of breaches that line. We use semi-rigid scopes, as I mentioned before, or sometimes rigid scopes to do pleuroscopy, medical pleuroscopy. As you know, surgical thoracoscopy is done with rigid thoracoscopes, video cameras, and rigid instruments in different ports. Recovery is usually very quick with pleuroscopy, either same day or overnight. Surgical thoracoscopy needs multiple days. The cost is lower, both in terms of equipment and per head with medical pleuroscopy. So I think this slide paints a picture of where the differences are and why there may be selected cases that medical pleuroscopy would be even superior to surgical thoracoscopy. One question that I really enjoy kind of exploring with my registrars and fellows is about how is it that even an elderly or a comorbid patient can tolerate medical pleuroscopy so well? And physiologically, it really is about the dependent lung getting the best of ventilation and perfusion. In terms of perfusion, it's quite obvious because gravity will direct perfusion towards the dependent lung. But in terms of ventilation, it really is because at a lower volume, the dependent lung sits at a better part of the volume pressure curve, the compliance curve, and therefore for a certain amount of change in pressure, you would have better ventilation or more ventilation. So ventilation is better in the dependent lung. Perfusion is better, and therefore VQ is better as well. So that's why they can tolerate an induction of pneumothorax in the contralateral lung and a procedure that could sometimes even last for an hour. How about anesthesia? Again, local anesthetics is really the mainstay of medical pleuroscopy, and often even by that and a bit of sedation, your patients can go through a medical pleuroscopy procedure quite comfortably. The pitfalls of and the principles of using local anesthesia in any invasive procedure have to be adhered to. However, dosing is very important, knowing the maximum dose and using it reasonably, knowing where the pain is mostly felt. Obviously, in medical pleuroscopy, that would be on the surface of the skin and also at the level of pleura, and using your local anesthetic on those areas. And one of the most common mistakes that trainees make is that they give the local anesthesia somewhere because the angle is different, and they start dissecting in another space, and that's obviously going to be painful. One of the things that we have, in fact, worked on and published, and it's a part of our routine practice now, is using inhaled methoxyfluorine as an anesthetic agent in not just medical pleuroscopies, but also in IPCs as well. Very well tolerated, really no side effects. We exclude people with severe renal impairment or liver impairment. And in fact, in that setting, we only use sedation in people who cannot have methoxyfluorine, and it's been very successful. So now the question is, how does medical pleuroscopy compare to surgical thoracoscopy? And this is a list of, a summary of like morbidities and complications that are reported with VATS versus medical pleuroscopy. And you can see medical pleuroscopy does really well in a lot of things, including pain, bleeding, infection, pneumothoraces, pretty much everything. But I think the reality there is that this is not a fair comparison. And the reason is because obviously you're including all the more invasive procedures that are done with VATS and comparing all of those complications with medical pleuroscopy. On this table, I've got a comparison in yield or success rate when it comes to medical pleuroscopy versus VATS. I think the important point here is that there are limitations with medical pleuroscopy that stops us from using it successfully in reaching, for example, mediastinal masses or lung biopsies, lung parenchymal biopsies, or doing resections. And that's where the advantage of VATS is. But when it's just about diagnosing, for example, for an undiagnosed recurrent exudative pleural effusion, then the success rate or the yield of medical pleuroscopy is very similar to VATS. Again, limitations, I'm going to skip through that in the because of time, but again, limited access. Of course, the scope is going to be limited with medical pleuroscopy as well, and expertise that are not widespread. So in summary, medical pleuroscopy is an old but useful technique that provides visualization and access to the pleural space in a minimally invasive way. And we can provide that under local anesthesia, maybe with conscious sedation from time to time, if needed, spontaneous breathing, single port. And it's well tolerated. And compared to surgical thoracoscopy, medical pleuroscopy has its specific role in some clinical scenarios, as it provides a comparable yield or success rate, which with a much more favorable safety profile and also cost-benefit ratio as well. So it really is about choosing the right indication. It is well tolerated, even in the elderly and comorbid patients. And I'm sure I've heard this quote from one of our Australian colleagues. I think it's Luke Garski, but because I wasn't sure, I didn't put his name down here, so a shout out to him. But this quote I love. It says medical pleuroscopy is really just an extended version of a chest drain insertion by dissection. So I might stop there. These are my references, and happy to come back to you, Gary, and answer any questions.
Right. Thank you, Taj. That's a very good rundown of the medical thoracoscopy and pros and cons. I might just start with very specific questions, but in the meantime, I encourage the audience, if you can put your questions in chat, and we can discuss it quickly. So you show in your pictures that you're using semi-rigid scopes, and I think a lot of our Asian audience will use that as well. But if you're trained in the UK, you're probably more likely to do rigid scopes, and that is almost like an eternal argument. Do you use Apple or do you use Microsoft? So what's your take on that?
Look, it's I think at the end of the day, it's back to access and what you have access to. I think they both have their pros and cons. To be fair, I think rigid thoracoscopy is a skill that I don't do. I don't do that procedure, but I do understand that you have access to rigid forceps for sampling of the parietal pleura, and that will give you deeper and larger specimens. There could be an argument that by using cryoprobes and doing cryobiopsies, which is now routinely done, you can kind of overcome that while using semi-rigids. I guess it could also be fair to say that, on the other hand, rigid pleuroscopes or thoracoscopes don't have that flexibility that you get with the flexi-rigid. Then visualization of the pleura is probably a little bit better. Access to corners, for example, to the apex, sometimes is a little bit better. I think that's the pain probably a bit better as well, because you don't require that big of a port with a semi-rigid. You can get away with a 0.5 to a 0.8 centimeter port, but you really need something at 1 to 2 centimeter port for a rigid. So there are pros and cons. I'm not sold to one way or another, and I think it's a matter of access.
I think a true interventional person would say the best is to have both, isn't it?
Yeah, absolutely. It would be lovely.
Now, about training, I think there's a lot of people in the audience who want to say, you know, some of the old-fashioned pioneers, they just taught themselves how to do it. But I think nowadays there's always training pathway for everything. What do you think if your trainees want to start, what is your recommendation to get training or accreditation? Yeah.
I learned from the CTEC course, and the beauty of that was not just, well, obviously talks and learning about the physiology and anatomy and your way around the pleura, but we spend a full day with live animals doing pleuroscopy, and that was really helpful. I think one of the very important factors here in any training is of a new technique is to make sure that shortly after the training course is done, you do have access to have some supervised work as well. And that's how I was lucky to go back to Concord and do a few with Matthew supporting me or supervising me. And then and that would be that's what I would recommend to everyone.
And a lot of people may not have surgical people on site as a backup. And that's always one question as to do you need to have surgery, thoracic surgery on site to be safe to do medical thoracoscopy? What's your view?
Oh, look, my view may be a bit controversial. I don't think surgeons are of much help in the immediate in the acute situation, to be honest with you. In fact, one of the reasons that Concord Hospital and we do probably about 15 to 20 a year on average, maybe more in some years, less during COVID. The reason that we have that service is because we don't have surgeons on site, and it's been working well. If there are complications, there are ways to manage them while you seek a surgical opinion.
Yeah. In your picture, you are doing it solo on your Concord or Macquarie picture. Do you normally have assistants, and what kind of assistant do you need?
Yeah, I do have an assistant. We usually start on either side of the bed while we are dissecting, but when we have the port in and have sucked the fluid out, we go on the same side, looking at the monitor on the other side, and the person assisting usually handles the probes and forceps. Yeah.
So there's a couple of questions online. One is, do you need to have a minimal amount of pleural effusion for you to go and do the procedure? And I guess that would lead to, what do you do if there's no effusions?
Very good question. I would answer that question in a different way. I don't think it's about the amount of effusion you have. I think it's about the possibility, the physiological ability of the two layers of pleura to separate. So when I do ultrasound before the procedure, I'm not looking for having a big pocket to get in. It will be nice, it will be easy, but I'm more after seeing the sliding of the two layers, because that basically tells me that if I induce a pneumothorax there, they will separate and I have a space to get in. If they're fused, not going to go anywhere. So if there is no effusion, then you can actually introduce it by using a bouton, a needle, which is pretty much just basically putting that
So I'm
in.
going to ask you a much more tougher question. The bouton needle has been taken out of production. You can't buy any more. So what would you do?
Controversial again, maybe. You can dissect
Yes.
carefully and put your finger in there. And the trocar itself is blunt, so when you put it in and open it to the atmosphere is the other is that Abraham needle. That's a bit sharp though, so you've got to be very careful with that. But that again, the side port introduces air into the pleural space.
Yeah. And just for the audience, the surgeons, that's how they would enter the chest for, say, lobectomy for lung cancer when that's dry. So it's not an uncommon thing to do at all. Yeah. So another question was, any tips on how to get the thoracic surgeon on your side?
Look, I think it's important to explain to them where medical thoracoscopy, medical pleuroscopy fits in that spectrum. Exactly how I was trying to sort of angle my talk is to avoid this concept that medical pleuroscopy is a substitute for VATS, in fact, it has its own role. It has its own indication, and just like anything else, when you and your surgeon are collaborating, looking at a big cohort of patients with pleural conditions, it actually creates more cross referrals. So you're supporting one another rather than competing with one another. If you can kind of create that understanding, I think that works very well.
Yeah. And just for the audience, you don't really need permission from the surgeons to do this. And also, at least in the public services, it takes any amount of workload you take from them is actually a win-win situation. What do you do when the pleural is tough? I mean, obviously you mentioned about cryoprobe, but I doubt if many of the audience has got access to that or feels entirely comfortable of using cryo in the pleural space. What other options have we got?
So I think you're referring to where the pleura is kind of like those kind of fibrosed or thick pleura that it's very hard to biopsy. So my approach is to use cryo. It is even in those, sometimes cryo is also very hard. I often start with the forceps and I try to create a dent by peeling and go a bit deeper, and usually deeper levels have more water content, and I can stick my cryoprobe there and then start biopsying from there. At every procedure, I mean, obviously I have already thought about why I'm doing it. Do I actually need a deep biopsy or not? Is this a case that I'm considering for mesothelioma? If that's the case, absolutely, I'll go for it. Obviously, I'm going to be careful that I'm on the rib. I'm not in between the rib. And if I'm on the rib, I feel reasonably comfortable to go as deep as I can, layer by layer, and try to sort of stick to one spot.
So another question is, how many biopsies or how many sites would you biopsy, and how many biopsy per site? Is there a usual rule of thumb?
Look, it is I suspect there's going to be a very wide variation if you ask that question from all pleuroscopies from here and there. I often stick to, if it's a diffuse, obviously if you've got abnormalities, you biopsy the abnormalities. If it's a diffuse process, I often do 2 sites, and I include the posterior recess, because posterior recess is often where things gather around, pathology gathers around.
Yeah. Someone wants to ask, what's the indication for pleuroscopy? I presume I'll modify the question a little bit as to when you would consider that, and when you would actually consider such percutaneous, say, ultrasound guided or CT guided biopsy instead.
Right. Look, ultrasound-guided biopsy, directly visualized biopsy, is a great technique when you can identify the abnormality on ultrasound. And in fact, I would prefer that if I can see that. There are studies, as I'm sure you're aware, and a few other colleagues in Australia are involved in that as well. The yield seems to be reasonably comparable to thoracoscopic or pleuroscopic as well. So if you have access to that technique, and when you're doing your ultrasound, if you can see enough thickness to allow for a biopsy, needle biopsy, I would prefer that to thoracoscopy. However, there are often cases that you're not just doing that procedure for the biopsy, for sampling. For example, you've got someone with malignant pleural effusion, you know it's probably going to be malignant, and you're going to make it a one-stop shop. Have a look at the visceral pleura, do your assessment about expansion, maybe even try expansion, whether you want to talc it or not, or just go into IPC and get it done. And often it actually speeds up the recovery for patients. So that's my practice. I try to in most of these patients with pleural disease, you want to minimize the number of procedures you do and their time in hospital.
So another question is, if you find yourself in the middle of a locule once you get in, how confident you are to break the adhesions, or should we avoid doing that because it is not a surgical thoracoscopy?
Look, it depends. There are adhesions that are chronic, and we see that often. Sometimes they have actually blood vessels as well. I would avoid them, and that's based on your assessment and your direct vision, and with experience that comes. However, in fibrin kind of locules, it depends on your tool. I actually use my cryoprobe. I use a 2.4 cryoprobe in the 3.2 channel or the 2.8 channel of my semi-rigid. It's brilliant. It's blunt, and it also has rigidity enough to be able to puncture through these webs of locules. And when you can poke through and see on the other side, usually fluid comes and you can see more holes, then you feel comfortable to go through with your scope and start dissecting them.
Great. And another question is about aftercare. I think, do you keep them overnight, or you discharge them on the same day? I think in the UK there's a strong push to do day stay medical thoracoscopy, but it's not very common in Australia, I don't think.
No, that's right. I mean, it may be possible, but my practice is to keep them overnight.
Yeah, so am I. Yeah.
Stay.
I think you need to be doing it very early in the day and just make sure that the patient is stable and there needs to be enough home support and so on and so forth. Yeah. So I don't think there's any more questions. I think everybody has learned a lot today. So thank you very much, Taj, and thank you for the audience for joining us today. And just a reminder that our next one will be on September 4th, and Deirdre Fisrow, who used to work in Australia, who is now in Ireland, will be talking about why patients get breathless with pleural effusion, which is a very important topic, and there's a lot of new data on it. So thank you, everyone. I look forward to see you next time.